Okay, kita nyo na?
Yes
Can
po,
you turn,
Doc.
Yes po, Doc.
turn on your slide. Turn your slides. Turn on your cameras, please. Okay. Hindi ko kayo nakita. Okay, so microbiology is a section of the clinical laboratory. And in microbiology, we study the bacteria, no? But it's also where fungi are also cultured. And other tests that would be pertaining to these organisms. Kasi when you say parasites such as your protozoals, they are in clinical microscopy. Okay. Okay. So we're going to talk about, or these are skills that you need to at least learn virtually, or by just looking at it. But these are also skills that you would have probably done in your microbiology subject. Okay, but we're doing this in the context of clinical diagnostics. So we'll talk about gram stain, acid-fast bacilli stain, culture in general, the workup, and subsequent to a culture, if you're able to ID a microorganism, you do microbial susceptibility testing. This is to guide the clinician on which antibiotic to use, or if the antibiotic is already causing resistance, or there is already resistance of the infectious agent to the antibiotics. Okay, so gram stain, this is supposed to be a video.
The gram stain is the most widely employed staining method in microbiology. It is a differential stain because it divides bacteria into two classes, gram-positive and gram-negative. In the first step of the gram stain procedure, cells from a fresh culture are transferred to a clean slide and allowed to dry. If the cells are on an agar plate, they should first be transferred to a liquid medium for dilution. The cells should form a thin, barely visible film. This can be achieved by smearing cells obtained from the surface of an agar medium or from a liquid culture. Fresh cultures must be used because as cells age, they lose their ability to retain the stain. The cells are then fixed to the slide by passing slightly above the flame of a Bunsen burner. After passing above the flame, the slide should feel warm when touched to the back of the hand, but should not be too hot. The fixed cells are then stained with the basic dye, crystal violet, for 30 to 40 seconds. The slide is then rinsed with water to remove excess stain. At this point, all cells appear purple under the microscope. Next, a solution of grams iodine is added and retained on the slide for about 1 minute. The iodine combines with the crystal violet, to form a diiodine complex, thereby decreasing its solubility within the cell. At this point, the cells still appear purple. The cells are then decolorized by washing with ethanol or acetone. This is the differential step. Gram-positive bacteria retain the crystal violet, whereas gram-negative bacteria do not. The ethanol or acetone should be added drop-wise, with the slide tilted at an angle until the drop coming off the edge of the slide just starts to become colorless. Even gram-positive cells can lose the crystal violet iodine complex during prolonged excessive decoloration. Excess ethanol is then washed off with water. When viewed under the microscope, gram-positive cells appear purple and gram-negative cells are colorless. Finally, the rinsed cells are covered with the counterstain safranin for 20 to 30 seconds. This stains the gram-negative bacteria pink. After rinsing with water, the slide is dried with filter paper. When viewed microscopically, the gram-positive bacteria are purple and the gram-negative bacteria are pink. Generally, the gram stain correlates with the cell wall structure among the bacteria. The ethanol is thought to shrink the thick peptidoglycan in gram-positive cells, thus retaining the dye. The thick, dehydrated peptidoglycan layer of gram-positive bacteria appears to be a permeability barrier, preventing the loss of the crystal violet iodine complex. In contrast, the peptidoglycan in gram-negative bacteria is very thin and has large pores. Ethanol may extract lipids and increase the porosity, thus removing the crystal violet iodine complex. Until the drop
Stained bacteria that are not decolorized by acid alcohol are called acid-fast. This stain is used to identify mycobacteria and nocardia. The acid-fast stain is an important test for the pathogens Mycobacterium tuberculosis and Mycobacterium leprae. In the gram stain, gram-positive bacteria were distinguished because they were not decolorized by acetone alcohol. A few species of gram-positive bacteria are also acid-fast. Prepare and fix a smear. Be sure the smear has completely air-dried before fixing. We will use the Kinyon acid-fast procedure. Cover the smear with carbylfuxin for 5 minutes. This time may vary depending on the reagents used in your lab. Wash the slide carefully with distilled water. Tilt the slide and aim the water above the smear. Let the water wash over the smear. Rinse the smear with acid alcohol for 1 minute. Rinse the slide by letting water wash over the slide. Cover the smear with methylene blue for 1 minute to stain decolorized cells. Briefly rinse the slide and blot dry. Do not wipe, just gently blot the slide. Make sure that the slide is completely dry before viewing it under the microscope. The cell walls of acid-fast cells have a high lipid content of mycolic acid. The cells with high lipid content were stained red with carbylfuxin, and the stain is not removed by acid alcohol. Acid-fast negative cells are decolorized by acid alcohol. These cells are stained blue with the methylene blue counterstain. When you have finished viewing your results, gently blot the oil from the slide and store it in a slide box.
This is another video for the bacterial culture. Yun palang intro ko ng EFB. Ano pala ako mute. Anyway.
Microbiological culture is the most important diagnostic technique used in medical microbiology. This is inducing the reproduction of microorganisms, these may be bacteria or fungi, on an artificial media in the laboratory. Microorganisms will multiply on this medium until they give rise to a visible colony. Each colony is derived from a single bacterium, a single fungus, or a clump of these. These colonies can then be tested in the laboratory in different ways. So, a sample from a patient is placed onto, the term is inoculated, onto culture media to determine if any organisms are present, and if they are present, what they are and how many there are. The two main types of media used are solid media and liquid culture. Solid media is made in a petri dish like this and contains a solidifying agent called agar. Only solid media will allow the production of single colonies of microorganisms, and so is the more important of the two. Liquid or broth culture is used less, but does have some applications which I'll discuss later. There are hundreds of different types of media available, and the reason for this is that different species of bacteria and fungi will vary greatly in their nutritional requirements. And this is linked to the huge variety of metabolic pathways utilized by different species of microorganism. So we need to match the nutritional requirements of any bacteria or fungi we are interested in and provide these in the media. Now, some microorganisms can utilize a large range of nutrients and will grow very easily in the laboratory, while others have more exacting nutritional requirements and are more difficult to grow. These are known as fastidious microorganisms. The simplest media contains a source of carbon, such as glucose, plus something like beef or yeast extract to provide nitrogen and amino acids, along with trace amounts of various salts. An example of a simple or basal medium is nutrient agar or tryptone soya agar, as shown here. Non-fastidious organisms such as Staphylococcus aureus and Escherichia coli will grow easily on this medium. Enriched media contains a basal media which is enriched with a substance to provide extra nutritional factors which allow the growth of more fastidious microorganisms. So, for example, blood agar also contains 5% sheep blood, and the nutrients and growth factors found in sheep blood help to support the growth of, for example, Streptococcus pyogenes and Streptococcus pneumoniae. Another enriched medium is chocolate agar, which does not actually contain chocolate, but instead is another type of blood agar. In this case, the plate has been heated to allow the red blood cells to lyse and release their contents. This medium is useful for the growth of, among others, Haemophilus influenzae. It is important to know where in the body the samples come from. This is not only because some pathogens only cause infection in certain sites of the body, but also because some parts of the body contain microorganisms, even in healthy people. So, for example, the gastrointestinal tract contains billions and billions of bacteria. Other sites in the body which contain microorganisms in health are the skin, the upper respiratory tract, including the nose and throat, and the female genital tract. So this poses a challenge for microbiologists. How do you find a pathogenic microorganism among the billions of other microorganisms present? It's like looking for a needle in a haystack. And the answer is to use selective media. Selective media contains something which prevents or inhibits the growth of many of the microorganisms which we are not looking for, while allowing the growth of the microorganism we are looking for. An example of this is Campylobacter media. Campylobacter is a genus of bacteria which causes gastrointestinal infections. This media is made selective as it contains a cocktail of antibiotics. Of course, the choice of antibiotics is important. The microorganism we're looking for needs to be resistant to the antibiotics used so that it will grow in the medium, while other microorganisms should be sensitive and therefore would not grow. Now this is Sabarod's agar, and this is a selective medium for the isolation of fungi such as dermatophytes, which cause skin infections, and Candida albicans, which causes a number of different infections. In this case, it is made selective as the pH of the medium is acidic, around 5.6, and this will inhibit the growth of many bacteria. Another selective medium is McConkey, which is used in the isolation of gastrointestinal pathogens such as Salmonella, and those which are often found in the gastrointestinal tract such as E. coli. This contains bile salts, which inhibit the growth of many bacteria. However, McConkey has another feature. It's not only selective, it is differential, which means it can be used to differentiate between similar bacteria which have different metabolic properties. And in this case, it will differentiate between bacterial species who ferment the sugar lactose with those which do not. And so, McConkey is known as a selective differential medium.
Antibiotic synthesis.
Microbiological culture is who ferment the sugar lactose with those which do not. And so, McConkey is known as microbiological culture is the most important. This is a selective medium. In this case, it is made selective as the pH of the medium is acidic, around 5.6, and this will inhibit the growth of many bacteria. Another selective medium is McConkey, which is used in the isolation of gastrointestinal pathogens. It is differential, which means it can be used to differentiate between similar bacteria which have different metabolic properties. And in this case, it will differentiate between bacterial species who ferment the sugar lactose with those which do not. And so, McConkey is known as a selective differential medium. Chromogenic media is a relatively recent development which is becoming widely used in laboratories. These types of media depend on us knowing a specific metabolic characteristic of the microorganism of interest. How this works is that the multiple modified substrates are incorporated into the media. The substrates are modified by the addition of a chromogen, a molecule which produces colour when it's cleaved. So each substrate is matched up with a particular microorganism of interest. If that microorganism is present, it will utilise the modified substrate as it grows. Therefore, the modified substrate will be hydrolyzed, releasing the chromogen and producing a coloured colony. And so the specific colour of the colony is an indication as to the identity of the microorganism. Robertson's cooked meat is an example of a liquid culture system which is used in the laboratory. It is exactly as it says, it's sterilised cooked meat and is used to allow the growth of fastidious microorganisms. The idea here is that a patient sample is inoculated into the cooked meat and this is incubated to allow any bacteria to grow. After 24 hours growth, a portion of this is transferred, the word is subcultured, onto solid media such as blood agar. After 24 hours in cooked meat, bacteria present in the sample have had the opportunity to multiply, increasing their numbers, and so there is a better chance of recovering them on solid media. So this technique is important as it is improving the sensitivity of culture. This is especially useful for the isolation of anaerobic bacteria, as they may become injured due to exposure to air when the sample was collected. Another liquid medium is alkaline peptone water, which is used to improve the recovery of Vibrio cholera, which causes cholera, a disease of the gastrointestinal tract. This medium is alkaline, as Vibrio cholera grows well under alkaline conditions, whereas most gastrointestinal bacteria do not. So this process helps to enrich for the presence of this species. So we've covered the basic types of culture media and provided examples of how they're used in the diagnosis of infection. Now, what also needs to be considered is the temperature and atmospheric conditions under which these plates are then incubated. So many organisms, such as E. coli, Staphylococcus aureus, will grow very happily in atmospheric air at 37 degrees C. For others, we need to provide a special atmosphere. Many fastidious bacteria prefer a carbon dioxide enriched environment. So, for example, if we suspect Streptococcus pneumoniae is present, we will incubate in an incubator containing 6% carbon dioxide. Some bacteria, known as anaerobes, are killed in the presence of oxygen, and we need to incubate these in an oxygen-free environment. An example of a pathogenic anaerobic bacterium is Clostridium difficile. Finally, while most pathogenic bacteria grow optimally at 37 degrees C, fungi prefer to grow at a lower temperature. And so when we attempt to isolate fungi, typically we would use an incubator at around 28 degrees C. Microbiological culture, known as anaerobes, are killed in the presence of oxygen, and we need to an example. Finally, while most pathogenic bacteria grow optimally at 37 degrees C, fungi prefer to grow at a lower temperature. And so when we attempt to isolate fungi, typically we would use an incubator at around 28 degrees C.
Okay, so that's actually the longest because it talks about the entire blood culture process and also the isolation of the different organisms that you can do in the microbiology laboratory. So if you're able to identify an organism by doing culture and by using differential tests, meaning tests that would eliminate one group of bacteria to another, and also using differential media or this very differential medium to allow to differentiate the bacteria if it can grow, if it cannot grow, if it's inhibited. It's basically by elimination. There's actually an automation on that. So once you're able to identify the bacteria, you're now ready to go to do the antimicrobial testing because you being doctors will be waiting for that. So this is how it's being done.
Antibiotic sensitivity testing. To determine the antibiotic sensitivity of bacteria, the following method is used. Soak a sterile swab in a diluted bacterial culture and press it against the inner wall of the tube to remove excess fluid. Carefully swab the entire surface of the Mueller-Hinton agar plate, ensuring that the swab overlaps each time to evenly distribute the inoculum. Turn the plate 120 degrees and swab again. Repeat a third time. Place the used swab in a swan bag. Then, using the antibiotic disc dispenser, stamp the discs over the swabbed surface. Incubate at 37 degrees overnight. After overnight incubation, examine your Mueller-Hinton plate. If zones appear around the discs, then the organism is sensitive to the antibiotic. However, if no zones appear around the discs, then the organism is resistant to the antibiotic. Sensitivity patterns can also be measured and recorded as either sensitive or resistant by measuring the inhibition zone size and comparing the results against a reference table of antibiotic zone sizes. If the measured diameter of the zone is larger than the inhibition zone diameter from the reference table, it is then recorded as sensitive.
Yeah, so the principle of antimicrobial testing is easy, no? You in a culture media where the in a culture medium where the bacteria, the isolated bacteria, the pure form of the bacteria will be grown um, on a plate or a plate medium, no? And then you put the antibiotic discs. If there is an inhibition, meaning there's no growth around the antibiotic disc, the bacteria is sort of scared to go in or are inhibited. And then the zone of inhibition um, will be measured, and that will tell you there's a cutoff. There's an established distance or the area covered to for you to surmise that it is sensitive. This is in vitro. Okay, in vitro susceptibility, but in vivo you'll never know. But in many studies, they usually correlate if it's sensitive. I'm telling you this when you become clinicians. Do not just solely rely on the susceptibility testing, because you can never exactly duplicate the behavior of organisms um, in vitro, I mean, in a laboratory. So you have to consider other factors, patient factors, also factors in how the tests are being performed. Okay, so we go to the next. Um, In the laboratory, we do fungal workups that are readily available. In the recorded, in the videos that you saw, you just watched, there was mention of fungal culture. I mean, fungal culture using Saborod's dextrose agar. Uh, and there are others, but that's it's like the blood agar plate of fungi, the Saborod's dextrose agar, or SDA. So aside from that, we can also do what is the equivalent to gram staining in bacteria is the KOH. KOH is not a staining, but rather you get a smear, or rather scrapings or any skin lesions or lesions that you suspect to have fungi in it. You put it on a slide and then you apply KOH. The KOH does not stain it. Okay, uh, it will only help in the cells, the squamous cells, in the case of the skin scrapings, to like spread and then or to disintegrate the attachment from one squamous cell to another, and the fungi to the squamous cells, para magiging makikita mo silang, mas makikita mo ang mga fungal or hyphal elements there. Okay, because it will dissolve tissue material, not necessarily the cells, but those connective tissue that bind the cells or the epithelial cells. So pag na-dissolve na yun, makikita mo yung mga fungal elements. They will be reported as presence of high-foul elements. India ink, on the other hand, is a negative staining. It does not stain the fungi, but rather it stains it colors the background black. So bagay na-discuss na to in your microbiology, or you're not having microbiology yet sa next STEM pa. So it colors the background black, and the fungi with their capsules, so hindi yun matatakpan nila yun, it will be walang cover ng India ink yun, that will look like halos. So those and that is specific to Cryptococcus. So you use this in CSF specimens. Another is germ tube test. A germ tube test is a culture-based test, meaning you grow the pure form or pure isolates of Candida. Okay, Candida species. Okay, so you want to know if which one will grow. Okay, so Candida albicans and Candida dubliniensis. Okay, this is KOH preparation video.
Demonstrate the KOH preparation for diagnosing fungal skin infections. The quickest and most accurate method for diagnosing fungal skin infections is the KOH preparation. While the fungal culture is more sensitive and specific, it can take days to weeks before the diagnosis is known. The first step is to scrape skin from the affected area onto a microscope slide. This can be performed with the edge of a slide, a scalpel, or a curette. Scrape the edge of the lesion to maximize the yield. A sharp skin curette is a very useful tool for scraping subungual keratosis or nails looking for onychomycosis. A cover slip may be used to move the scrapings into the center of the slide before applying KOH. In this case, a fungal stain with KOH is being used. 2 drops of the Schwartz-Lambkin stain will stain the fungal elements blue and begin to dissolve the human cells. A cover slip is placed on the slide, and the slide is heated briefly with a flame. Heating with a flame is optional, but often speeds up the process of human cell dissolution, making it faster and easier to find the fungal elements. Examination of the slide starts at 10 power. The clinician looks for clusters of cells with associated fungal elements such as hyphae or pseudohyphae. While looking for fungal elements, it is important to use the fine focus to search up and down through the specimen, keeping in mind that the preparation is three-dimensional and hyphae may be seen better at one level than another. Once structures suspicious for fungal elements are identified, the objective is switched to 40 power to confirm or dispel the diagnosis. The most common causes of false positives occur when the clinician overreads overlapping cell borders or other artifacts as hyphae, or overreads micelles from topical medicines as yeast forms. The goal is to find fungal elements on high power with definitive fungal morphology, such as septate branching hyphae or pseudohyphae with buds. False negatives occur when the scraping is inadequate or the clinician does not look at sufficient low-power fields to screen the slide. See how the fungal stain helps the fungal elements stand out from the human cells and therefore increases the sensitivity of the preparation. These slides at high power show other examples of positive KOH preparations for dermatophyte fungus using Schwartz-Lambkin stain. This technique can also be used for Tinea versicolor, with the result showing Malassezia furfur with a ZD and meatball pattern. It is often difficult to tell the difference between a fungal skin infection, an eczematous eruption, and psoriasis. A properly performed KOH preparation is a powerful tool in the diagnosis of skin diseases.
Capsule staining. To prepare an India ink wet mount for microscopic examination of Cryptococcus, pre-flame a loop to ensure it is sterile. Using the sterile loop, place a loopful of saline onto a microscope slide. Re-sterilise the loop. Take a small amount of growth from a well-isolated colony on a blood agar plate. Make a light suspension by emulsifying the yeast in the saline. To the naked eye, the suspension should be barely visible as cloudiness. A cell suspension that is too dense will make it difficult to examine the cells. Re-sterilise the loop. Add an equal volume of India ink to the yeast suspension, using a drop from a plastic transfer pipette. Mix with a toothpick until the suspension is homogeneous. Discard the toothpick into disinfectant. Place a cover slip on the slide. With a clean toothpick, gently press down on the cover slip. Examine the stained wet mount by standard bright field light microscopy. Start with the 10 times objective and ensure the condenser is raised. Once in focus on low power, move to the 40 times objective. If a capsule is present, it will exclude the particles of India ink and the capsule will appear as a clear halo around each cell.
Firstly, the straight wire is flamed. Then, colony from the agar plate is transferred into the serum in the test tube. The colony is suspended in the serum. The test tube is ready for incubation at 35 degrees centigrade for 2 to 3 hours. After incubation time, a drop of the suspension is placed onto a clean microscope slide. The clean cover glass is placed over the suspension. The slide can be examined under the microscope.
So those are the slides and the video. You have questions? We're now going to proceed to that. We have 30 minutes to do that. So the case presenters, please present now. The floor, the floor, the screen, and the audio are yours. Bonnie, sino absent? Paki-take note mamaya ha, pag doon sa ano, kung absent.
Yes po.
Kasi magkaiba yung absent sa hindi nagsalita.
Sige po.
Okay, bilisan natin. And then, lahat magmema na agad.
Hello po.
Okay, please proceed.
So our case po is about hemoglobin part. So for our case history po, so case, our patient is RE, a 32-year-old Filipino Gravida 1 para 0 at 29, 4 or 7 weeks of gestation, admitted due to palpitations. She has a known history of anemia treated as iron deficiency anemia. However, she denies any history of abnormal bleeding or blood transfusion. Her family history, personal and social history were unremarkable. At 10, 5 or 7 weeks of gestation, her complete blood count CBC showed normal hemoglobin and hematocrit levels of pregnancy with microcytic and hypochromic RBCs. Repeat CBC at 23, 2 or 7 weeks of age of gestation showed anemia with persistently low RBC indices. She was advised to continue taking her iron supplement and prenatal vitamins. So at 29 weeks, age of gestation, her congenital anomalies can reveal fetal cardiomegaly, mild pericardial effusion, and mild ascites. The rest of the findings were normal and was then referred to a perinatologist and a pediatric cardiologist where fetal 2D echo then revealed normal cardiac structures, cardiomegaly with the heart filling more than 80% of the thorax, revealed pericardial effusion, ejection fraction of 64%, and slightly elevated aortic pressure signifying heart failure. Assessment at this time was fetal hydrops and fetal cardiomegaly. So for the laboratory findings, low hemoglobin, hematocrit, low RBC on 29 weeks of gestation, high neutrophil count on 29 weeks of gestation, and low lymphocyte count on 29 weeks of gestation. So for the peripheral blood smear, it has a marked anisocytosis, hypochromic, and microcytosis.
For other laboratory findings, expanded numerous screening revealed elevated levels for hemoglobinopathies and presence of hemoglobin Barts, indicative of possible hemoglobin H disease or alpha thalassemia. Hemoglobin electrophoresis revealed presence of hemoglobin Barts. Next slide. So for our patient identifiers, again, our patient is RE.
Wala kayong ano, yung, or sa discussion na yung electrophoresis na...
sa discussion na po, sir.
Okay.
It will be explained later po. Nationality Filipino, religion Catholic. She works as a teacher. She was born in 1990. She was born in and lives in Peru, QC. This is her first admission dated November 5, 2022. Next slide. Her chief complaint, she came in because of palpitations, so history of present illness. 30 minutes prior to consult, patient noted sudden onset of palpitations while lying down. No precipitating and aggravating factors were noted. Palpitations was slightly relieved when drinking water. No associated symptoms were noted. No medication was taken. A persistence of palpitations prompted her to go to the clinic.
Next, physical examination. So the vitals of the patient, temperature 37.0 degrees Celsius, heart rate of 132, blood pressure of 130/90, and respiratory rate of 21 cycles per minute. General appearance, the patient appears lethargic but conscious and coherent, alert, responsive, and oriented to time, place, and person. The patient's dressing is appropriate, neat and clean, and the patient is cooperative, rational, and friendly. Skin is in normal texture, normal turgor, warm, dry. Eyes, for the eyes, pale pink mucosa with visible signs of pallor, no scleral icterus. For the neck, no lymphadenopathy in posterior cervical chain, no thyromegaly. For the heart, PMI non-displaced and heart of normal size, no trill or gives, RRR, S1, S2 with no S3 or S4, no murmurs, rubs, or gallops. For the lungs, slightly increased work of breathing, lungs clear to auscultation bilaterally, no wheezes or crackles. Extremities normal capillary refill, no edema, clogging or cyanosis. For the abdomen, non-distended, no scars, normal active bowel sounds, no bruit, non-tender to palpation, no hepatosplenomegaly, and no masses. Neuro, alert and oriented, a strength of biceps, triceps, hand grip, finger spread, hip flexion, knee flexion, and knee extension, 4 over 5 bilaterally. Cranial nerves, 2 to 12 were grossly intact. Tandem, gait was normal, symmetric. Sensation, intact to light touch, and sharp versus dull on distal arms and legs. Proprioception is intact.
So for the next part, for the laboratory findings and the radiologic findings. So here, yung tabulated form lang ng laboratory result ni patient. Meron siyang result, 3 laboratory results from 10th week, 23rd week, and 29th week of gestation. So discuss na lang natin yung mga pertinent findings ng result ni patient. So first is yung hemoglobin. Mababa yung hemoglobin all throughout dun sa tatlong weeks na tinest si patient. For the hematocrit, mababa lang siya nung 10th and 29th week. For the RBC naman, mababa siya or decrease siya nung 29th week of gestation. And yung WBC count ni patient during 29th week of gestation is increased. And yung next slide please, for the peripheral blood smear, it is nakita sa lab result ni patient is hypochromic microcytic ang RBC, and also normal to slightly elevated yung red cell distribution weight, and yung platelet count naman is normal. Next slide please. So for the result of the hemoglobin electrophoresis, the presence of high levels of gamma tetramer and very low hemoglobin F in conjunction with high hemoglobin H and hemoglobin A2 are highly indicative of 4 alpha chain deletions, which is suggestive of hemoglobin Bart. And makikita natin dun sa electrophoresis result, based dun meron tayong control and yung result ni patient, makikita natin yung spike dun sa or there is an increase dun sa hemoglobin fraction ng HbH and Hb Bart. Next slide please. So for the radiologic findings, sa right side, makikita natin yung congenital anomalies. Ito yung nakuhang radiologic findings during 29th week of gestation, which shows cardiomegaly and mild pericardial effusion. And on the left side, may ascites, 29th week of gestation pa din. Intact naman yung diaphragm, and the kidney of the patient are normal in size, and yung bladder is fluid filled. Next slide please. So for the ultrasound done 4 days later at 29th week of gestation, it shows progression ng fetal ascites as shown by the increased anechoic fluid in fetal abdomen. Next slide po.
So next po is for the diagnosis. So first, we need to do a history and physical examinations. So this focuses on family history since thalassemia is a hereditary disease. For the age of onset, it can also classify if it is a major or a minor thalassemia. So onset at or before birth suggests alpha thalassemia major. And usually the severity of symptoms of HGB Barts disease is more severe po. So next, for the laboratory testing like CBC and hemolysis testing. So microcytic hypochromic anemia is typical in all thalassemia syndromes. Then the RBC count are increased, especially in hemoglobin Barts, but can also be seen in thalassemia minor. The RBC count is often helpful in distinguishing thalassemia from iron deficiency anemia. So for the reticulocyte count, it may be slightly increased, but not to the extent that would expect from the severity of anemia, especially in the beta thalassemia. Next is for the hemolysis. It included lactate dehydrogenase, indirect bilirubin, haptoglobin, and Coombs testing. So thalassemia causes non-immune hemolysis with high LDH, high indirect bilirubin, and low haptoglobin with negative for Coombs testing. So thalassemia does not directly affect WBC and platelets. So for the hemoglobin analysis and genetic testing, they are required to confirm the diagnosis of thalassemia. So the diagnosis of thalassemia is best confirmed by globin gene testing to detect if what globin is affected. Genetic counseling is also advisable for families affected by this condition to promote understanding of the significance for themselves and future offspring. Then for the prenatal testing, it involves taking a sample of amniotic fluid or tissue from the placenta to show whether your baby has a thalassemia and how severe it might be.
Good afternoon. So now let's talk about the pathogenesis of hemoglobin Barts. Next slide, please. Okay, so hemoglobin Barts is also known as alpha thalassemia major, and it is considered as the most severe form of alpha thalassemia. It is inherited in an autosomal recessive manner, and affected genes are hemoglobin alpha 1 and hemoglobin alpha 2 genes, which specify the production of alpha globin protein chains. So in here, there is severely reduced or absent production of alpha globin chains. Next slide, please. Thank you. Okay, so because there is severely reduced or absent production of alpha globin chains, fetal hemoglobin is not formed, but instead, hemoglobin Barts is formed from 4 fetal gamma chains. And hemoglobin Barts has high oxygen affinity, which makes it an ineffective oxygen carrier. So the fetus presents with anemia, edema, ascites, gross hepatosplenomegaly, and cardiomegaly. And consequently, fetus with this type of hemoglobin would have severe intrauterine hypoxia, leading to the intrauterine death of the hydropic fetus late in pregnancy or at term, although a small number survive with aggressive transfusion therapy, as seen in our case. Thank you.
So for treatment and management, so hydrops is mostly an incidental finding on perinatal workup. The underlying cause has a direct influence on the development of symptoms and its prognosis. Careful evaluation, monitoring, and effective resuscitation techniques are essential in improving the survival rate in affected neonates. Early diagnosis is central in the management of HB Barts hydrops fetalis and may show potential in improving prognosis. The prenatal and postnatal management of HB Bart, it requires both resolution of anemia and reduction of the relative percentage of Bart's hemoglobin, as both measures serve to increase oxygen delivery. Next slide, please. So for fetal interventions, these interventions include intrauterine transfusion for prevent fetal anemia, maternal antiarrhythmic medications for fetal arrhythmia, and utero surgery. So these interventions lead to prolonged gestation, improved APGAR scores, and shortened neonatal mechanical ventilation. Okay. So after birth, patients require lifelong and intensive transfusion regimen. Treatment is controversial since most treated infants surviving the immediate postnatal period subsequently show abnormal development. So these patients may be considered for hematopoietic stem cell transplantation. So postnatal management includes initial resuscitation, identification, and treatment of the underlying cause. Most of the infants with hydrops fetalis will require endotracheal intubation because of respiratory depression. Paracentesis, and sometimes cardiosynthesis are performed if the neonate presents pleural effusion, ascites, and pericardial effusion. In cases of severe anemia, a blood transfusion is given. Furthermore, close monitoring is needed if tachyarrhythmias are transient or intermittent. If severe, they are corrected with cardioversion, antiarrhythmic drugs, and pacing. That's all po for our report. For our reference report.
Any question for our presenters? Ha? Oh, may mahan time na ngayon. What is the pathology involved in Barts hemoglobin?
Alpha thalassemia po, deletion po ng 4 alpha globin chain.
And iba naman. And how is that detected in the laboratory? Is it the absence?
Electrophoresis, Doc.
Sa ano ang makikita mo sa electrophoresis? Iba naman. Iba, yeah.
High levels of gamma tetramer po, Doc.
Gamma tetramers, which is, that's the structure of your Barts hemoglobin, diba? So what's the problem with Barts? With the hemoglobin, that hemoglobin pa rin naman siya. So what's the problem with that? Uy, anong problema sa Barts? Kapareha niya ba yung hemoglobin A, A2? Ano pala ang normal sa iba naman? Anong normal hemoglobin meron ang tao?
Hemoglobin A po, Doc.
Hemoglobin A? Ano pa?
Hemoglobin B po.
Hemoglobin B. Ano ba hemoglobin B? Wala yata hemoglobin B. A2. Walang B. Ano pa isa? Hindi sila hindi nila sinusunod ang alphabet. Ano pa? So may A, walang B. Hemoglobin A?
A1C.
Siguro medpic tinitest kasi yon, hemoglobin A1C. Yeah, subtype of hemoglobin A1. There are other subtypes of hemoglobin A, no? Hemoglobin B, wala. Type B lang na, no? Meron bang hemoglobin D? Hemoglobin E?
Doc, F po.
Wala po, F lang po.
F na kaagad, no? Okay, sige. So, yun yung normal hemoglobin. And them being normal, can they function? Ano ba? This is like a no-brainer question. Well, what's the expected function of your hemoglobin?
Carry po oxygen.
So, carry oxygen po.
Hindi. I expect a more detailed answer. No? How does it carry oxygen? Sige, pero may stick na yun. Paano? Sige.
Transferring po the oxygen.
How can it transfer first? How does it do it? How does...
Doc, may binding sites po. May 4 binding sites for the molecules.
So, mayroon na rin sticks yan. Hindi ko nakita yun. Yeah, it binds to oxygen. And then, para maidala niya, di ba? So, sige. Ano na nga yung tanong ko? So, what's the problem with hemoglobin F? Maganda nga ito. Ang dami niya hemoglobin pero hemoglobin F.
Mababa po yung hemoglobin F.
Ay, sorry. Barts hemoglobin. Anong problema? Kailan? Ayun, sa hemoglobin F. Para lang dumami ang tanong natin. Sa hemoglobin F, in a normal adult, marami ba to? Or meron ba dapat?
Po, sa normal adult.
Ano siya?
Less than 1% po yung hemoglobin F sa normal adult.
So, kailan siya nakikita?
Sa mga fetus po siya normally.
Fetus? Kasi hindi naman ang hemoglobin mo at that time Yes, sige. Santos, would you like to say something? Sige.
Sorry, Doc. During gestation po siya nakikita. Sa
sa pregnancy na pagka gumagana na yung kanyang kailangan kasi ng oxygen, di ba, pero hindi naman, it does not come in contact with the pulmonary oxygen, di ba? Hemoglobin F, Pwede siya in utero and it might persist in a few days of life. No? Tapos pagka-adult ka na, hindi na because it's the normal hemoglobin na ang nagbabind to oxygen. Ano pa nga yung tanong ko sana kanina, hemoglobin. So what is the problem with your Bart's hemoglobin? Hoy.
Dok, mataas po yung oxygen affinity pero hindi niya na papasa sa tissues.
It has a strong binding capacity to oxygen but it keeps it. So hindi rin naman niya maano no. Hindi niya na para kang ano. Kaya anong magiging kulay ng ano theoretically anong magiging kulay ng fetus at that state?
Cyanotic po, Dok.
Hindi siya cyanotic kasi ano siya. Alam niyo yung ano the effect of cyanide and even in ano na nga in carbon monoxide. Wala pa kayong ano no. O kasi first sem pero I used to lecture it yung environmental pathology. In carbon monoxide ano
Ako nag-lesson ng environmental ngayon.
ay ikaw na ba? I hate that lecture. Anyway, yun sinasabi niyan. Abangan niyo si Dr. Francis. Siya mag-lecture ng ano. So that will be part of the ano.
Na-discuss na po Dok yung environmental.
Na-discuss na. So anong magiging kulay ng carbon monoxide?
Cherry red?
Cherry red wine. Anong shades of red ba dapat? Meron kaming teacher dati na wala na pala si sir sa ano, cherry red. Anyway, sige. Ano pa nga yung hindi natanong nasagot-sagot kanina? Oh, let's go to diagnostics. How are you going to diagnose? Okay. Hindi lang malinaw sa history yun, no? Gusto ko lang linawin. Pwede namang sumagot yung... gusto ko sumagot yung mga non-reporters. Ang nanay ba merong Bart's hemoglobin or yung fetus? Hoy. Ano lang hulaan ninyo?
Yung fetus po.
Yung fetus po, Dok.
Oh, ang daming tatlong ano. Bakit hindi pwede ang nanay? Kung wala ang nanay, bakit meron ang fetus? Oh. Lahat na ba nakapag-mema, Bonnie? Bilis naman.
Gene-related po, Doc.
Gene-related. Very generic, no? Pero that deserves a stake. Okay, yeah. Ano yung genetic problem in this case? Babalikan ko, may itatanong pa ako about that. Bakit wala ang nanay, meron ng anak? Sige, ano ang problema, ang genetic aberration dito sa or what's the genetic abnormality? Sinabi nila yan, I know.
Yun po ba yung loss of all 4 alpha globin alleles?
Yeah, it's deletion. Di ba merong, ano bang mga genetic aberrations? Uy, deletion, substitution, ano pa mga ibang So yun, hemoglobin genes, your alpha hemoglobin, globin genes, your alpha globin genes. Okay. Ano na nga yun? Meron ng reading sumagot, bakit wala ang mayroon ng baby pero wala ang nanay.
Dok, kasi po yung gamma nakikita lang sa newborn. Tetramer of gamma.
Hindi. Yung F yun, hemoglobin F yun. Diba? Hemoglobin, your gamma globins, dahil walang alpha, sila ay nagsama-sama to become your Barts hemoglobin. Pero ano nga yun? Bakit ang mother meron, ang baby, ay ang mother wala, ang baby meron? Ano? O reporter, saan ba nanggaling ito? Sa tatay, sa nanay?
Doc, possible po na carrier po yung mother.
Carrier yung mother. Carrier siya ng fetus. Okay. Oh yeah, carrier mother. Tapos, bakit wala siya? Meron pala siya. Ay, may carrier naman pala siya. So, anong kaibahan niya dun sa fetus? Uy, reporter, hindi nyo inaral to.
Dok, kasi may 4 types po.
Okay, sige. Ano yung 4 types na yan? Hindi, reporter ka
Una
ba?
po, Dok.
Sino ba yung nagsalita? Sige.
Guantero po ako nagsalita.
Gualberto yung nagsalita. Oh.
Silent po, Dok. Tapos alpha talaga.
Reporter ka ba?
Minor. Ay, hindi po.
Hindi. So, ano yung types na yon? Silent, may noisy, may mema, may ano pa yung iba? Saan wala dito sa report ninyo yun? I would probably ask that in the quiz na lang. Punta na tayo sa diagnostics. Okay, so how is this diagnosed? One is electrophoresis. Ano pang iba? Ano pang ibang ginagawa? Ano yung mga pinagawa nila? How do you investigate?
CBC and hemolysis po, Doc. Testing yung ginawa.
Okay. What was remarkable, sino yung nag-present nun? Pinakita niya yung CBC yun, di ba? Yung ilang days by, ano yun, sa age of gestation. Anong pinakita nila? What were they trying to highlight? Hoy, ano na? Ano pa yung ibang test? Pakita mo nyo nga, reporter. Please show your slides.
Prenatal testing po, Doc.
Prenatal testing. Sige, pakita nyo nga, Okay. Ito yung sa mother. Kaya nila, di ba? Na pick up nila na there's something wrong because the mother is having anemia. And they thought it was, what type of anemia were they thinking?
Iron deficiency.
Yes, iron deficiency, anemia. But hindi sa anemia, anong nakita? Nandyan na pala. Since walang value, ano dapat ang value ng MCHC and MCV dito? Hoy, andyan na Para lang masagot ninyo.
MCH, Doc, below 27.5.
Yung MCB po, less than 80.
Oo, kasi it's small. And then they're small, di ba? Your MCH is hypochromic. Pwede itanong dyan. Bakit mataas ang neutrophil at mababa ang lymphocytes? Next slide ka na, reporter. That question, bakit mababa ang lymphocytes at mataas ang neutrophils? Oy, ano na? I think pala yung Barts hemoglobin, that's the hemoglobin B siguro because it starts with B. Pero I don't know, okay, hemoglobin B. Baka meron na, hindi ko naman. Ano na yung tanong ko? Uy, ano na yung tanong ko? Iyan mo lang para may maitatanong pa tayo, reporter. Just Just keep it. Just share it. Ilan na ang may mema, Bonnie? Na 5:02 na. May class pa kayo after?
Wala po, Doc.
Doc,
5 na lang po yung hindi nakakamema.
5 na lang? Including yung absent? Oh, pumasok na yung
kompleto po
absent.
tayo.
Hindi, kanina 31 lang yan. Okay, next slide. Sige, para makapag-mem. Let's go to the 5 na How do you, or what is your reaction to this case? Kaya alam nyo naman kung sino kayo hindi pa nakapag-mema, kaya mag-mema na kayo. Baka na hindi kayo na-detect ni Bonnie kasi yung mema ninyo ay lang, secondary mema. Next slide nga. Sige, next slide. Sige, wala na radiologic na, wala kasing gaanong. Ayun, diagnosis. Ano ba yung diagnosis na nilagay ninyo? Wag na yun. Sige, next pa. Next. Baka may tanong pa tayo. High RBC count, hemolysis. Sige, next. Oy, walang makakasagot. Bakit mataas ang kanyang neutrophils at low ang Sige, next slide pa. Kasi nasa akin yung written report niyo. Sige, pathogenesis, naitanong na natin yan. Okay, this is our last bahala kayo kung hindi kayo mag-mema, punta na nga tayo doon sa sa feelings ngayon. How do you feel about the patient and the fetus?
Doc, sad.
Sad.
Sad po,
Habaan mo
Doc.
naman kung
Doc, syempre po sad, and then kahit papaano nafe-feel ko yung po, kalungkutan ng patient, then saka nung fetus, kasi syempre baby niya pa rin po yun. I think wala rin po siyang understanding regarding sa history kung ano
what could have been done? What could have been done para like for the subsequent babies, anong pwedeng gawin niya? I mean, I'm not expecting you to answer it technically or according to the book. So ano dapat ang ginawa pala para na-prevent ito? Ano siya? Ano sa tingin mo? Dapat ba pinili niya yung asawa niya or ano? Or hindi siya inasawa ng asawa niyang, ng lalaki? Halimbawa ikaw ito, anong magiging desisyon mo sa asawa mo na ganito? Palitan mo. This could be ground for divorce.
Actually, pag ako po siguro yung nasa posisyon, before po po siguro yung baby, or kung meron po kaming merong subsequent na magkaroon ng chance na magka-baby, we'll talk about it po. Na if ever there's this chance na yung baby is having this HB part na ganito, if she would be ready, or we would be ready ba to have this kind ng situations na pwedeng mangyari dun sa buhay namin. And yun lang po.
Sige. Naman, let's hear it from the woman's point of view. Kasalanan mo ba na nagkaroon ka ng carrier ka ng Barts? So, sasabihin ng asawa mo, naiba na tayo ngayon, hindi na yung technical na. Sasabihin ng asawa mo, let's have a divorce because there's no point we can have a baby, a normal baby. So, anong sasabihin? Sinong magsasalita sa ganang kababaihan? Walang mga matatapang na mga babae dito. Walang magsasalita. Isusuko na lang ba ang paninindigan ng mga babae? Ano lang naman, parang discussion lang naman, kuro-kuro. Wala. Sige, let's go to another feeling. And what are other feelings that you have? Who can say something about chordocentesis? What is chordocentesis? Hoy. Wala? Hanap tayo na ibang word na pwedeng itanong. Uy, ano na, alas 5 na, weekend na. Wala na talaga magsasalita or baka kasi nasa ano na sila, Bonnie, nasa biyahe na kaya hindi sila makapagsalita. Okay, shall we close this? This is our last case discussion. Wala kasing gaanong ano nito. Walang gaanong mapag-usapan kasi yun lang naman the genetic defect and then diagnostic, which is just hemoglobin electrophoresis. Diba? We would not go to to the clinical and the treatment because that's not ours. This is CD. No? Sige, kung wala, then I have to say this is a weekend. Your weekend starts now. And I hope you will have a happy weekend. Next week will be the practical exam. Meron naka-miss ng ng smear. So remind me, ano pa ba? Don't forget your long gowns.